probably get started. Thank you everyone for joining us this morning. I'm gonna let Prasant go ahead and kick us off. Just a reminder to keep your microphones muted, keep your camera off too, unless that you're called on to speak by the moderator or one of the panelists. It just helps with the overall keeping the background noise low. So let's get started.
Thanks, Ana Lucia. Good morning, everyone. My name is Prasant Mahapatra. I serve as the Vice Chancellor for Research. Once again, welcome to this Friday session on team research. So this is, as most of you will know, that this evolved starting from March 2020. And I would say that among all the bad things that has happened, this is one really good thing that has evolved over the last 2 years in building up this team of organically growing research environment to talk about important research, and not only related to COVID, but beyond. So today we have pretty good attendance. More than 200 people have already signed in. We will be talking about COVID-19 and the Omicron variant. Can we go to the next slide, Ana Lucia? Before I hand it over, I just want to highlight what's coming up during this quarter and the next quarter. 11th of February, we'll have Dr. Carol Burns, the new Deputy Director of Research at Berkeley Lab, talk to us about a broad research partnership. Then we'll have Lawrence Livermore National Lab presenting on February 25th. March 11th, we will focus in-house with the interdisciplinary research support team on DEI in action. And in the month of April, we'll have the Department of Economics from UC Davis. Dr. Catherine Russ will be talking about food safety issues. We will, towards the end of the spring quarter, we'll have the College of Biological Sciences presenting structural biology at BioEM. Dr. Baldwin will be giving a presentation on that. We are looking for more opportunities in having people join us. There was a last minute addition on Omicron, the South African experience. This will be something that I'll be personally also interested deeply in listening to Dr. Sabid Mahdi. So let me, at this point, let me quickly hand it over to Dr. Kim Barrett, Vice Dean of Research at School of Medicine, to kick off today's show.
So thank you very much, Prasant. If we could go to the next slide. So I want to acknowledge our panelists and others for providing just some general data to put today's discussion in context. It's not going to be a formal presentation. It's very much a panel discussion with our panelists responding to questions that were sent in ahead of time or can be asked live this morning. And so Angela will be introducing our speakers more formally, but thank you to Richard and Brad and Stu for being here, especially at a time that's obviously so busy. So this is the updated UC Davis data. And as Prasant alluded to, perhaps we're seeing a little turning of the corner in terms of the positivity rates. I'll note, since I still have access to data from UC San Diego, that these are actually considerably lower than the rates that are being reported in Southern California, or at least in San Diego. So to that extent, perhaps there's a little light at the end of the tunnel and also some positive news. But as you can see, in terms of the running total of patients and the total number of patients per week, UC Davis is definitely not out of the woods by any means, with a very significant uptick that actually is exceeding the patient rates from last winter. Next slide, please. This is just to put in context of worldwide data, and you can see that the Omicron impact on overall cases is really being felt everywhere. And of course, already now over 5.5 million deaths have been reported, but perhaps encouragingly closing in on 10 million vaccine doses administered. And it's likely a combination of the vaccine rates, but also perhaps evidence emerging, and doubtless this will be in next week's presentation also, that perhaps the Omicron variant is less lethal than others, which is not to say that they cannot cause very serious disease, particularly in those who are not fully vaccinated. Next slide, please. So in California, this sort of mismatch between cases and deaths is quite evident. Now, obviously, death rates are a trailing indicator, but it's certainly encouraging that even though there has been this incredibly sharp uptick in the number of confirmed cases in California, the death rates certainly have not, thankfully, kept pace with that. Next slide, please. And nevertheless, there is a huge stress on the health system at Davis and everywhere else in the state. Again, you can see the number of hospitalized patients is climbing very acutely, and there is a general downward trend of the number of ICU beds available. You can see on the left-hand side of this slide that just in one day, there was a 5% increase in hospitalized patients. And obviously that sort of number of cases is not sustainable, particularly in the context that a lot of healthcare workers are also either succumbing to COVID infection themselves or have been exposed. And so we have very significant challenges in terms of having enough staffing in the hospitals to take care of this surge of cases. And I think that may be the last one, or is there one more, Ana Lucia? Oh yeah, okay, so this is again, the Healthy Davis Together data and Healthy YOLO Together data. And you can see that actually the Davis positivity rate is lower. What's really extraordinary is that there's currently 8,000 to 9,000 tests per day being conducted, with the majority of them getting a report in the same or the next day, which is really an amazing testament to the work of our colleagues who are on the panel this morning. So the campus rate overall is much lower than Yolo County. Doubtless the high vaccination rate on campus has something to do with that. And I do think that is the last slide now. So I will turn this over to Associate Dean Haksu, who will introduce our panelists and moderate the discussion.
Thank you very much, Kim, for joining us and doing this presentation. It is my absolute pleasure to introduce our panelists for today's session. We are very appreciative that you carved out some time to answer our anxious questions this morning. Our panelists are Professor Brett Pollock, Department Chair for Department of Public Health at the School of Medicine, Professor Richard Michaelmore, who is Director of the Genome Center at UC Davis, and Professor Stu Cohen, who is the Division Chief of Infectious Diseases at the School of Medicine. So I would like to start with a few questions that were pre-submitted to this session, but we already have questions posted in the chat, and please continue to do so. And I would like to ask Ana Lucia to help me with monitoring the chat questions. I'm just going to go by the order we received these questions. So the first one is, my neighbor tested positive and was told not to test again through HDT for 6 months. Why? Maybe this is an appropriate question to Brad to answer, and perhaps you could also elaborate a little bit about these rules. Fairly confusing for everyone, and I see that coming across that last few days all over the place.
Sure. The primary reason for not testing again is that there's clear evidence that if you've had an infection, it is possible for you to have remaining RNA present without you, in fact, being infectious for others. And remember, the whole point of testing is to block the transmission to other folks, right? That's why we do this. So it's number one that you may end up having positive PCR results going out, but probably more importantly, your likelihood of sustaining another infection where you're viremic over a certain period of time. And I'm not, 6 months, 3 months, there may be some argument about that. And especially as the variants are creeping up now, the biology of the virus and the dynamics have changed. But the idea here is you're not likely to have another full infection for a certain period of time after you've had a wild type of infection. So, and of course, it's a resource issue too, right? If we could test for nothing and do this every day, it might be a different story, but it's also to conserve a little bit of a resource use that we have here, that there really isn't a lot of utility in you getting tested for a certain period of time. Now, again, 6 months may be, arguable. And as is evident here for this pandemic, we've been looking at data emerging, and, the whole thing is changing every month or two. We get new evidence here. So that period of time to wait for retesting may change as the virus changes over time.
Thank
Can I
you.
jump in? I think the official recommendation is 90 days.
Yeah, that's what I thought too. Yeah.
It's 90 days, not 6 months.
Yeah.
And the thing is, if you do it because you want to be sure whether you're not infectious, and you come up positive, let's say 3 weeks after you've first been symptomatic, that will trigger everything that says you should isolate and things like that. So you really don't want that.
Yeah.
So you're shedding virus, it's dead, you're not infectious. And what you want to do is about 90 days, that's when you're potentially going to be reinfectable.
Yeah. But that could change also, Richard.
Exactly.
Yeah.
If the virus changes, but currently with what we know about the variants, you don't want to get tested by PCR. Now you can get tested with antigen, because that's different.
Yeah.
And where I think a lot of the confusion comes is the talk of whether you want to have a negative antigen test so you can test out of isolation. And people seem to be flipping on this, both at the federal level and the state level. I don't know whether you want to weigh in on that, Brad.
Yeah, well, I feel sorry. I feel some empathy for our CDC director, Rochelle Walensky. I think the scientific community was very lined up. Remember, we've just had guidance about shortening the time for you to remain isolated if you have an active infection. And they've shortened the time from 10 days to 5 days. When the CDC came out with the recommendations, they did not tie getting out, and this is if you're asymptomatic and 5 days out from getting detected, they said you can go back to work, so to speak. And a lot of the scientific community had a problem with that, which is that we didn't feel that was quite safe enough. And I think internally within the CDC, I'm sure they had the same discussions. I mean, people are very bright there. But the problem was we just didn't have the testing kits available for the public. And so it's difficult for the feds to issue guidance when you can't do it. You can't follow the guidance. So they kind of said, well, okay, we're not going to have the testing requirement. There was some backlash, even within 3 days or 2 days of Rochelle coming out with that. Fauci was on the Sunday morning talk shows and said, well, maybe we should be doing this. And a lot of us felt that having a rapid antigen test that was negative was going to be okay. I actually went a little bit further than that. I think having 2 rapid antigen tests a day apart would have made me feel a lot more confident about returning earlier than the 10-day period. But this is a balance between politics, practicality, and science. And, it's been very difficult to navigate this successfully. So
yes, so Stu had a comment because I think testing is extremely relevant for healthcare workers, and I would like Stu, if you could comment on this. And one question just came up asking what is antigen. So Stu, could you please also answer that?
Yeah, to be honest, I'm not sure which particular target the antigen looks for, but the test we use here is by a company called Diasorin, and over the last week, we probably tested somewhere in the range of 300 healthcare workers, somewhere in that range, and about 60% of them have been negative at day 5. So it's a way of getting at least a percentage of people back to work. It would be nice, actually, as was mentioned earlier, for some of our immunosuppressed patients to be able to get them out of isolation. Right now, based on the initial CDC guidance, we keep people isolated for 20 days if they are immunosuppressed. Immunosuppression is not all one bucket. And so there are a bunch of mixed metaphors in their list of immunosuppressed patients. So there may be some people where we could get them out a little bit sooner by doing antigen testing. Maybe all of them don't need to be in 20 days. And so I think it ultimately is another tool in the toolkit that allows for a little bit more precise management of people than what we've been doing.
Yes, and somebody, I think Bart Weiss, asked how does presence of symptoms align with antigen presence?
Yeah, so we don't even test them if they're still actively symptomatic, right? So if they're either asymptomatic or significantly better, that's when we test them. If people are still miserable, we don't test them.
And
right.
Andrew Hamilton is asking about infectiousness and how infectiousness is related to presence of symptoms.
Yeah, so people are probably symptomatic for the most 2 days before and 2 days after, maybe 3 days after they get infected. That's when the peak of the viremia is present, or the peak of the virus in the oro and nasopharynx. Then it drops over time, right? As people start developing an immune response, that's when you start seeing viral loads come down, just as with other viral infections. So I think that that's the basis for what the folks at Healthy Davis Together are doing, right? Is that people not only can be asymptomatic all the way through, but they can surely be transmitting pre-symptomatically. And it turns out, I think if you talk to our employee health people, the majority of people have some symptoms. They may not be particularly impressive symptoms, but the majority of people ultimately have some symptoms, even if it's just a stuffy nose or a sore throat for a day or two.
Excellent. Thanks so much. We are learning so much from this. It's really great that the session is actually recorded. So if you need to re-listen to what's being said, please contact Ana Lucia for that. So the next question is related to the Omicron variant of concern. Is it genetically derived from Delta or an earlier variant, and how different it is in regards to symptoms from other variants?
Well, I can take on the phylogeny. It is quite clear that Omicron did not come from the Delta lineage. It is, if you look, it's got a large number of mutations, and if you map them onto the very large new millions of sequences that are now available, it is clearly a different branch. And the thinking is that possibly it came from an immunosuppressed HIV infected patient in South Africa, where there was a long period of which the virus could mutate and accumulate so many mutations. Now, a point to make in addressing some of the other questions, any organism mutates all the time. The virus is going to continually mutate. But most of those mutations won't confer an advantage. And you've got to think, and if you're going to want to know where is COVID going to go, you think about the selection pressures. if you have a vast number of individuals, which we do, and you have a steep selection pressure, it's going to evolve in that direction. And what's happened over the last year or so, the selection pressure has been for increased infectivity. And that's what we've seen progressively, right? Now you've got another steep selection pressure is vaccinated individuals. Something that obviously overcomes the vaccination is going to be more successful. And so that's what we're seeing here. Now, in terms of symptoms, some of those changes may have secondary effects on the parts of the body that get infected and the symptomology. Another thing you need to put out actually is if you think about a pathogen like a virus, it's failed if it kills you, right? So the virus is not out there to get you. It's there to infect. And so it's not really an advantage to rapidly kill. So if you want to anticipate where it's going, but it doesn't necessarily mean that the next variant may be more pathogenic than Delta or Omicron. Hopefully it won't be. But the direction is for increased infectivity and increased infectious period.
Thank you. The next question is.
Actually, I think Brad wanted to weigh in on some of the symptoms.
Yeah. Sorry.
Yeah,
Go ahead.
so Richard's exactly right. The selective pressures are the things that are going to dictate what's going on. But it is not necessarily to say that another variant couldn't pop up that is much more transmissible, which is, again, in the virus's interest, but coincidentally could, in fact, be more lethal. That is theoretically possible. We don't know, unfortunately. And people are kind of relaxing, saying, oh, we're moving toward an endemic disease and it's less severe and everything else. Omicron may be the case example of that, or it may be the counter example of what may happen. So I don't want to put fear into people, but it's not okay that we've got, Omicron right now. And there was a really interesting quote from Jerome Adams. If I could, I'll just share the slide real quick. I think it's kind of useful to see this. But this was a tweet he did on Tuesday, okay? And he said, scientists and media, please stop telling people Omicron is milder. He says, if your enemy uses a weapon that's a third as likely to kill you, but 4 times as many people are shooting at you, you're now 1.3 times more likely to die. So this is really an important point, which is, it's serious business right now. And if people are kind of relaxing, saying, oh, it's just the evolution that we're going to get into something like influenza, which is also a very serious disease. I don't want people to relax. And this relates to some of the other questions here about, hey, I'm vaccinated, I can go out and do anything I want. Not anymore, because there are these post-vaccination infections happening now quite readily. So it's a serious thing for us to be concerned about.
Yes, so both you and Richard mentioned about overcoming the vaccine-induced immunity by these sneaky viruses. So how does that work? I mean, these viruses have the same antigens that we develop these neutralizing immunoglobulins against. Mm-hmm. So how is it possible that they escape that and fully vaccinated and boosted people get infected by Omicron regardless?
I'll just add real quick that it's a matter of timing here. If we were able to develop vaccines and get them out in a week or two, we could stay ahead of this thing. We know there are trials going on with the Omicron programmed into the messenger RNA, but we're not using those right now. And I think that's the issue. It's not a matter whether we can kind of keep chasing this. I mean, with influenza, we try to predict the next mutations, right, for the season. With this virus, we've seen now a number of these variants of concern arise. I think the issue is, while we've developed vaccines in record time, can we do that fast enough to keep up with this chase with the mutation rate and with these variants kind of arising in populations? That's a bit of the issue. And again, you think about other diseases where you have multimodal therapies, right? Where you're attacking, like cancer, you may have one pathway that's the primary pathway for the etiology of a tumor. But when we do chemotherapy, you develop resistance quickly. So most of our chemotherapeutic regimens for cancer use, multimodal approach to hit multiple pathways that may arise. So we may have to take some other strategic decisions about how we're going to do this in the future. But we've developed vaccines very quickly, but we don't have Delta and Omicron specific vaccines out there in the market right now.
Right. So
You know, one of the things I will just say, I appreciate all those comments, but you know, the coronaviruses are not as mutable as most RNA viruses. It's the absolute sheer number of cases that is driving this endless rate of mutation, and the immunosuppressed populations, as Dr. Micklemore mentioned, right? This is these are the keys, right? The people who keep replicating over and over again, you just start spewing out mutations. And if people were vaccinated earlier, and the disease, we didn't have 1 million cases a day in the United States, we might not be seeing as many variants popping up. This is right. I mean, we see this not just in cancer, right? This is how we manage TB. This is how we manage HIV. This is how we manage hepatitis C. But Hep C and HIV mutate so damn fast. It's very different than this. And the populations of viruses are being developed in the individual patient, not in the population. And so this is a different problem. And the problem is that you can't have 1 million cases a day where even a rare mutation is going to be carried forward by the same mechanisms as were mentioned already. That's my brief editorial comment, or maybe not so brief. I'll be quiet.
It's a great comment. And I think that actually also speaks to the issue of we missed our containment opportunity for this thing. Because again, if we were able to have kept the numbers down, we wouldn't have had this pandemic play out the way that it has. And I think, the other thing is we are still looking at the vast majority of the world's population that has no protection. And so I think we've got a lot of challenges that are still facing us going forward. But containment would have been great at the beginning of this thing. Too late now, right? Now we went to mitigation. I think the other thing is when vaccines were available, they are available now, but the fact that we've had slower uptake than what we thought would happen, I think that's also contributed to this. But it is a very difficult problem, and we may have to look at some other strategies, as Stu said. Looking at multimodal approaches to dealing with this is probably going to be what's going to happen.
Yes, so actually there are several questions related to the vaccine, and especially to children's vaccination, because I mean, let's face it, they have spread the disease big time in families. So one question is 3 microgram mRNA a high enough dose in your opinion? And also any projections on when boosters will be approved for 5 to 11 years old that are also school age children? So who would like to answer this?
Stu, you want to try?
I wasn't listening. I was getting something
yes,
else.
Sorry.
I'm on service, so you got to ask me again.
Yes, so it's about children's vaccination. One question is, do you think the 3 microgram mRNA is a high enough dose for the under 5 years old? And also any projections, in your opinion, when boosters will be approved for 5 to 11 years old? So basically, a lot of parents are concerned about their school age children, and it's a concern for society as well.
Yeah, and I don't think I can answer either of them other than supposition. So since many drugs and vaccines are weight-based, the decision to cut the Pfizer vaccine by 10-fold was weight-based, and therefore the expectation is that it should be that dose should be fine. But that's why the clinical trials have to go on. As far as boosting, I know that they have started trials boosting the 5 to 11-year-olds. I don't know how many patients they will need to be able to go back to the FDA to get the approval, but I would guess that surely before springtime.
Yeah, and I also just to comment, you're probably all aware that the trial being done in the 6-month-old to 4-year-olds was sort of not put on hold, but modified very quickly. After 2 doses, they were not able to elicit the kind of humoral response that they were expecting. And so there was additional arm added to do 3 doses. And that's not super uncommon with some childhood immunizations. I work in childhood cancer mostly, and it's not uncommon to see normally 2-dose schedules extended out to 3 doses because of some underlying immunosuppression. But again, that's going to put a crimp on getting the very young kids vaccine available. So we'll probably be looking sometime at March or so where the data get put together for the 3-dose schedule for the very, very young kids. But as you all know, it takes subjects, takes volunteers for these trials. The fact that we're able to get the adult trials done so quickly was just because of the massive number of new cases, and the event rate was high enough to be able to do these in a matter of 3, 4, 5, 6 months. So it's not quite as easy with younger kids. It's going to take a little bit longer.
Yes, and one piggyback question is related to combination of various vaccines. What's your opinion? Would combined approach, combining the mRNA with the DNA or the attenuated viral vaccines, how do you think that what would be the best approach for protection?
So it appears, first off, the NIH did some clinical trials with that. The data are available on the CDC website in their slide set, but the full publication, as I remember, is not out.
Yeah.
It appears that the adenovirus vaccine is just inferior to the other 2 as far as developing antibody responses. If you boost somebody who received mRNA vaccine with the J&J vaccine, they get a less vigorous response than if you give them another dose of mRNA vaccine. And if you boost somebody who gets J&J with an mRNA vaccine, they get a better response than if you give them a second dose of J&J. I'm just, this is a total editorial comment, but J&J has been a pain. This whole thing, we don't know when to give people 3rd doses. It's just been a giant headache, and I'll leave it at that. I don't want to make any more statements that can get me in trouble.
Well, I'll make one statement. I think many folks said J&J was a marketing ploy. Basically, it should have been a 2-dose all along, and they wanted to have a unique place in the marketplace, which they did with the selling the 1-dose business there. I'll also point out that the UK was ahead of us too with AstraZeneca, and then adding in the messenger RNA stuff. So there was a fair amount of data, and it's interesting. Nothing has really emerged by using this mixed strategy, and as Stu said, it looks like the mRNA vaccines just elicit the best response, at least the best humoral responses. It still we still have to play out what's going on with cell-mediated immunity. And, that's kind of the unwritten part of this whole thing here. We don't know what's going to happen long term, but I haven't seen any strategies emerging now where you're doing that vaccine mixing as an optimal therapeutic or preventive approach.
Yes, and with the widespread Omicron presence, now we heard that it looks like immune protection is actually synergistic with the infection. So one question from Hazel Meredith Bayaj is how soon after you got infected with Omicron could you or should you get a 3rd or a booster vaccine? What's your recommendation?
Yeah. Stu, you please take that.
Well, I mean, we're telling people to wait a month. I don't think there's a magic number. Initially, we had people wait 3 months. When the vaccine was in short supply, with the idea that the immunity with, at least with seasonal coronaviruses, lasts probably at least 3 months. And so we thought, okay, we could hold off on giving vaccine doses to people and maximize those who had not been infected. What does appear to be the case, though, is that if you give it too soon, I think people get more, and this is purely anecdotal, but I think they get more systemic reactions to the vaccine. So we try to give them a little bit of a breather before we boost them. So I've been recommending a month time off.
So a couple of interesting questions came up related to co-infections or infections with the flu as well as COVID, and somebody mentioned fluvid. So what do we know about this situation other than we all should get the flu vaccine as well?
I don't know.
No, I gotta defer to somebody who's a virologist, but I can't even imagine that, right? They're totally different, right? Coronavirus are single-stranded positive sense RNA viruses. Flu is a segmented RNA virus. I can't picture it. Those cards don't seem to be shuffleable to me, but I don't know.
There was a very little bit of data from the initial MERS infections. There was a couple, and it looked like they were antagonistic infections. That if you have flu, there were cases where people were infected with one, but it was like just 1 or 2 papers that came out 20 years ago or something like that.
It kind of makes sense, not just for innate immunity reasons, but interferon, other things that are going on when you have a viral infection. But right, I don't know.
Getting co-infection, I can picture.
Yeah.
Ending up with a variant of virus that mixes the two, I cannot.
Yeah.
Thank you. Yeah, that was good to clarify. Otherwise it would be like a very scary sci-fi movie the rest of our lives. So Cheryl Pater is asking that out of the death that we saw from Kim's presentation, how many are assumed to be due to Omicron proportionately? Is there any knowledge on that?
You're talking about the mortality rates being tied
yes,
to
the mortality rates.
Yeah.
If you are sure that the infectious virus was Omicron.
I haven't seen the data yet, but that's not surprising since we're talking about this surge that really is peaking over the last month. I mean, this takes a while to get these data. I know that we are getting either sequence or genotyping data on variants now, as a fairly routine thing. I have to give Richard credit for it wasn't routine last January when we started this. I mean, it was really quite innovative and important. I don't think we have the database yet. We certainly have seen vaccinated versus unvaccinated mortality rates, 17-fold differences and so on. But I don't know that we've actually kind of drilled down yet on terms of the mortality attribution. And again, it's changing by the day, right? It's just, you're dealing with a very dynamic situation with the introduction. And now it's 98% of all cases. So, you won't have much of a comparison cohort at the same time, unfortunately, but.
Yes, and now as we know much more about how to treat the severe cases and the ICU treatment policies changed completely, there is a much better handle on severe. Yeah. Sorry,
one of the other things that is maybe not totally clear to people who are not working in the hospital is that probably 2/3 of the people who are admitted right now are not being admitted for COVID. They're being admitted for something else, and they are identified as being infected with SARS-CoV-2. So I think trying to tease out whether somebody who ran their car into a truck is dying of COVID or not is a little bit more challenging. So the absolute mortality rates may not totally reflect the mortality rates related specifically to the viral infection.
Yeah, so I'll just add to that, Stu,
Okay.
that San Francisco County has all the hospitals in San Francisco for many months now have been reporting separately those cases that were admitted for COVID-19 versus incidental finding admitted for some other reason. That's been separated out. And surprisingly, Placer County has been doing it for many months. They instituted that reporting for political reasons because they wanted to sort of decrease their numbers a little bit. But San Francisco does have those data. George Rutherford shared that with me. So they're able to look at that. And I think you're seeing now that the reporting standards are being changed. That California is going to start requiring hospitals to report that split between due to or incidental to.
Yes, that will be very useful. Another piece of statistics, and Andrew Hamilton is asking, do we know now the exact degree of infectiousness over time following initial symptom emergence, first positive test for the Omicron variant? I assume that's what he's asking about.
I'm sorry, Angela, can you repeat that? I didn't quite.
Yes,
Yeah.
so do you have, at the beginning we knew exactly what was the infectiousness rate for the SARS-CoV-2, but what about the Omicron variant being so extremely infectious? But is there now a good estimate? What would be a reasonable number for the infectiousness?
I've heard double Delta. But I mean, I think there's still probably some, reporting bias and lots, different anecdotes around. So I'm not sure, but it's clearly significantly higher than Delta was, and Delta was already, threefold higher than the original wild type. So it's much more transmissible. And I'm not sure, Stu, whether it's kind of approaching measles or not. But it's probably not a huge, not orders of magnitude off like it was at the very beginning.
Yeah, I think it's about 7 or 8 people infected for every case, which is a little less than measles, which is 12 to 18.
Yep.
Scary. Thank you. Sachadan Dakar is asking about treatment, and I know we have the new drug, the Paxlovid, but what about Favipiravir, which worked well for flu? It also seemed to help with COVID infection, but anybody would like to comment on this drug?
I think there were some small studies in the U.S. with Favipiravir that didn't pan out very well. I think one of the things, we have learned stuff in 2 years. It feels sometimes like we're stuck in the mud, but we've learned a lot. And one of the things that we've learned is that the antiviral drugs are much more beneficial really early on in disease than they are late. And they're probably better at preventing people from getting really sick than they are from actually curing people. And I think that, which is a slightly different model, although it's the same model that we use with oseltamivir for influenza, right? It's, so I think the idea of the Paxlovid, which is a combination of a protease inhibitor, I think that's pronounced nirmatrelvir, with ritonavir, since we've never really seen data other than on a Pfizer website, it's sort of amazing that we're diving into this, and the sum total of publication is their press release. But that said, it looks like it's very active and is effective in preventing progression of disease. But even drugs like remdesivir, which we used in the hospital, which may have shortened duration of hospitalization, but never really had an impact on mortality. It keeps people out of the hospital if you give it to them as an outpatient, right? 3 days of remdesivir is about equally effective as Paxlovid for keeping people out of the hospital. So I think, so it might be that when the clinical trials with favipiravir were performed, they weren't really looking at the right patient population. I think there's a lot more focus on outpatient management now to try to keep people out of the hospital rather than addressing people once they get in, where problems become much more difficult to address.
Yes, so there is also an interesting question regarding to behavioral differences between vaccinated and unvaccinated people. And Andrew Hamilton is asking, is there any data on whether vaccinated versus unvaccinated differences in mortality could be due to behavioral differences between US subcultures?
So you're not talking about
So people who go for vaccination are also more likely to wear a mask and that sort of thing.
Yeah, I thought you were talking about viral behavior, but if you're talking about human behavior,
human behavior.
Oh yeah, there's no doubt that all of those social determinants of health and all these potential confounders are playing a role there. I mean, I have to say, as an epidemiologist, that is why we like to have large data sets with complete data. So, you could actually tease apart these effects. But there's no doubt that folks that, got vaccinated, if you were to look at their behavioral characteristics, let alone their political leanings are different, not 100% different, but there are factors that certainly correlate with that. But unfortunately, we can't calculate the incremental differences. That's because we just don't have those data sets available to us.
Right. It would be hard to conduct a study like that, because we are actually promoting everyone to get vaccinated and to wear their mask anyway. So I think the remainder of the time, I'm trying to synthesize a few questions, and it will be fun because I'm asking about your predictions. So people were asking, what do you think that this huge Omicron surge was due to a coincidental holiday season and intimate gatherings? We saw that similarly last year also, and based upon this, do you have any predictions for next school year? People are worried about 2022-2023 school year. What can we look forward to? And yes, someone was asking, when will this pandemic end? So.
Well, let me take a quick stab, and again, I wish I had been able to monetize my predictions. Now, they're only good for about 2 or 3 months out in the future. But first of all, I want to just take you back about 2 months ago with Healthy Davis Together. This is a project that we did not see going on forever. In fact, we had about a 1-year window when we started this thing, which was really September of 2020, and of course, things didn't quite work out the way we expected them to. But about 2 months ago, we were trying to figure out how much to pull back our testing capabilities in Davis. And so, from a very practical standpoint, how do we staff? And unfortunately, because we're at a University of California campus and we've got HR and everything else, if we had staff that we're going to have to let go, we had to give them enough notification and so on and so forth. But really what we had expected 2 months ago, before Omicron really reared its head here, was that we would definitely not see a fall off in new cases during the holidays. And in fact, we sort of predicted that we'd expect there to be either, a stable number of new cases, not continuing to fall like we were doing, going back 4 or 5 months ago, but it would be stable or maybe go up a little bit. And I know Tom Nesbitt even mentioned the Super Bowl in February, that we would be seeing more social gathering. And so we were trying to figure things out in terms of timing for pulling back. And then Omicron hit us. And so all bets are off. Okay, so I just want to say, you can do all the modeling you want, and I've learned a lot more about modeling. I remember as a graduate student taking infectious disease epidemiology, we got to play around with stochastic and deterministic models. I have many folks, including Miriam Nuno in our department, who does predictive epidemiology and modeling. The modelers didn't get it exactly right if you looked at the longer term forecasts. And I really don't want to stick my neck out and say, next year in September of 2022, I should say next academic year, where we're going to be. I don't know. Nobody could have predicted the path that we've seen here. What I'm hoping, though, is as we get more people vaccinated, that's part of the deal there, as we hopefully will get a lull after the Omicron thing here, I'm hoping that we will get things under better control. And so I'm not saying it's hopeless. And I think what Stu said also is we are not in the same place we were, 20 months ago. We have learned a tremendous amount. I am not wiping down my groceries that I get from the grocery store. We've learned a lot about this thing.
That was a good.
Yeah, well, and I think so. That knowledge is not going to be wasted. And I have to say, I think the biggest issue I have is it is human behavior, and it's the lack of scientific literacy in the population. Telling people, first not to mask, and then with evidence showing that masking is effective. And then trying to talk to folks saying, first you tell me not to mask, now you're telling me to mask. What's wrong with you people, right? That is evidence of a lack of scientific literacy, health literacy in the country. So I do think we have a big challenge. We only have about 70% of the California population fully vaccinated, and only maybe about 30% of those that are boosted. That's 30% overall being boosted. So why isn't it 99%, 95%? That's a big question. That's a social question. I think that's going to play into what happens with the dynamics of the pandemic over the next year.
Yeah, watch the movie Don't Look Up. I highly recommend it.
Exactly. The sky is falling. The comet's coming. Yep.
Yeah, it's still more interesting about celebrities and that sort of thing. So, well, anyway.
Something else that there's a whole new generation of therapeutics that are coming online extremely fast. And Stu can probably comment more, but I've seen research studies of exquisitely effective chemicals. It's just a matter of time before they come online, and you'll be able to have prophylactic and Stu, where are therapeutics going to play into all of this?
Well, as I mentioned already, I think we, right now, as with everything, there's never quite enough of what we need. But we've been giving a lot of monoclonals over the course of this pandemic. We were one of the sites that demonstrated that prophylaxing family members with monoclonals was effective in preventing the family members from getting ill. And the problem with monoclonals is that as the virus changes, they're not as effective. And so the one that we do have now, which is called sotrovimab, is in short supply. Last week, we got a total of 6 doses. Next week, we're supposed to get 18. It limits what you can do. So there has to be a scale up of those things, but the oral antivirals are really going to be the ultimate place where you can start looking at this in the same way as you look at any other infection, particularly any other acute infection. I mean, this is different than HIV and Hep C, but it's going to be managed like an acute infection. And I think we have to have the diagnostics to be able to drive people to get treated early. And then we have to have stuff that we can use to treat people and the prophylaxis. So all those trials are either partially in progress or moving forward. And then the vaccines are getting, will become more modified, and probably will end up being like flu vaccine, where you're getting multiple strains with each vaccine. And, though I've still never figured out what's going on with this operation. I believe Novavax is finally going to the FDA this month. That works as well as the mRNA vaccines, and is maybe a little bit more palatable for some of the people who don't like the idea of mRNA as the sole reason that they're backing off. I will also point out that we have to start changing our definition of fully vaccinated, because 2 doses 5 months out is not fully vaccinated anymore. It's not boosters, it's 3rd dose of vaccine.
Yeah, thank you. And in regards to prevention, we also have some specific questions. People are asking what your opinions are about cloth masks and KN95, and which one should we do. My preference is just cloth masks anyway.
No.
But
No.
yeah.
I'm going to say this. I think the original reason that people said don't use masks is because we didn't even have enough masks in the hospital. If you remember, people in New York were putting bandanas around their mouths while they were taking care of patients. So I think some of the decisions are made based on supply. I think that the evidence is clearly that even a poorly fitted N95 or a KN95 that you buy over the counter is more effective at preventing both virus getting out and virus getting in. Those N95 masks not just have a tighter fit, but they also have some electrostatic charge that goes along with it as well. And so really, if you, particularly with Omicron, if you really want to be as good as you can be to prevent transmission, it should be an N95 or a KN95, followed by a surgical mask, and followed by a cloth mask. And the cloth masks that that were handed out in my division actually have filters in them, right? They have paper filters in them too. So it's not the same as getting a cloth mask with teeth on it or something like that, so that you can look funny. And so I think that's the other thing.
Yeah, the other recommendations are, surgical masks are the second line next to the N95s. But a surgical mask worn with a cloth mask over it allows, essentially traps those gaps that you might have in a surgical mask. So that's another recommendation now, is to use a surgical mask underneath, put a cloth mask over it to sort of make sure it conforms to your face.
Yeah.
Not as good as a well-fitted N95, but I just saw some data this last couple days about how many hours of contact you would need with each of those different types of masks scenarios there. And I know with the N95s, you were looking at 24 hours of being with somebody to get adequate exposure. Cloth mask was a matter of about 15 minutes, and there was everything in between. But I do think that, that's turned out to be an important strategy. The other strategy is not to be around people that are shedding virus, right? Let's go back to those principles here, to be outdoors as much as possible, to make sure you've got good ventilation, keep your distance. Those are also important, characteristics, principles that do work along with the masking.
Yeah, thank you so much. And one last question about ivermectin, which has been all over the media and everywhere. And Sean Adams is asking, so can anyone venture?
I saw a great little cartoon or a photograph of somebody standing next to a horse. People are not horses.
Well, I mean, we use ivermectin in humans. I know that horse thing has been a big to-do, because that's where you can get it. is going to an animal feed store. But we use ivermectin in humans for several of the helminthic infections. It's an effective and relatively safe drug. It's really made a huge difference in Africa with river blindness. It's not a horrible drug, but the tests with SARS-CoV-2 demonstrate that it doesn't work. And so, I used to get in conversations with patients about this stuff, but now I don't anymore because they just spout off stuff that they hear on particular TV stations. And I don't have the interest in arguing with them because I can't change their mind, no matter what I do.
Yeah, my neighbor here is a pharmacy, he actually owns a pharmacy in Sacramento. He was popping hydroxychloroquine. He and his wife both got infected. Come on. So, that's why we do trials. That's why we actually do formal evaluation and test hypotheses. It's not the safety issue, it's the efficacy and the safety. Both of those they have to be worked out.
Thank you so much. And I know we could go on forever here because the questions just keep popping up, but unfortunately we didn't have enough time to answer all of them. But please try to get the recording of this, and there was just a goldmine of information in everything that you were saying. We are absolutely grateful. Thank you for a fantastic session. This was very useful, and we had over 250 people listening in. So thank you again so much. Everyone have a great weekend. I don't know, Prasanthi and Kim, if you would like to say a last word before we say goodbye.
Just stay safe out there.
Thank you.